What a great VIP day. There are so many VIPs here today, we can't mention them all. I know Pam told me this is, Pam and Jim told me this is one of the largest pharmacist turnouts we've had at VIP Day. So thank you so much for taking a day out of your business, a day out of your practice. And we really appreciate these legislators. Please thank them when you see them walk out, when you see them over at the Capitol, when you see them back in their districts. Really thank them because they do such a great job. I see Bruce right here in front. What a great representation they do, carrying the torch, working for us every day. Well, when you talk about carrying our torch and our profession's message, I can't think of a better person than Tom Menighan to carry our torch. And he is one of us, folks. There's a really nice write-up on Tom. I'd have to give you a 30-minute CD program of all the things he's ever done. But he is a pharmacist, true to the profession. He's done a great job. He is a former and currently still an independent owner in West Virginia. He's an innovator. He has obviously a pharmacy degree and an MBA. But he leads us day in, day out up in Washington at GPhA. He's currently the CEO of GPhA, the American Pharmacists Association, which Mike Pavlovich is also here from the GPhA Board of Trustees. Please help me, folks. Read over his bio, listen to his message. Let's give him a great Georgia welcome, Tom Menighan.
All right, I just heard my mic go live. So, thank you so much today. Wonderful to be here. So many friends I've seen since I came in this morning. Always get a welcome in Georgia. You folks really know how to do it. Lots of people to recognize. Certainly Jim Bracewell, he and I go way back and have some stories to tell that I won't share with you this morning. Pam and Jonathan Marquis I knew when they were in student leadership at GPhA, and I was in my first tour duty there as a staffer. We go back a long way too. Governor Deal really set the stage for you today by saying that you are a logical extension of healthcare in this country, and you got that right. He also said that that the system really needs you. I'd say he got that right too. There's a lot of logic going on, but at the end of the day, when you hear someone speak, you don't necessarily remember the words that they said. You remember how you felt when you listened to it. So at the end of this conversation with me this morning, I hope you know that pharmacy is together right now more than we've ever been in my 30 years plus of hanging out in national pharmacy circles. That our star is rising as a profession, that awareness is growing in our communities that we have something to offer, and that capacity is in place. And you can see that in this room today. Some people complain that we have too many pharmacy schools. I say we have an embarrassment of riches and new practitioners who are primed and ready and well-trained, incredibly well-educated, and have the capacity to go out and truly change the way primary care is delivered in this country. And when you walk away today and you do what you're going to do today, keep that in mind, that we really do have something to offer. So you may be aware that in my work as exec, that GPhA has a publication called Pharmacy Today, sort of our news magazine. Well, I try to be helpful where I can, sort of the other duties as assigned sort of thing, and Pharmacy Today was going a big story on OTC diagnostics. And so they needed all of the things to put together, put them on a table, and take a photograph of various OTC diagnostics. So I volunteered to go pick them up. So I went to a pharmacy where nobody knew me, and I went in and I picked up the various test kits for yeast, UTIs, glucose, strep, pregnancy test, and just for fun I picked up some duct tape. Duct tape is used for everything. And I put it all down on the counter, and this young lady was checking me out and going through these things, and you could just see the wheel turning. what's going on here, what's going on here. And as I finished up and paid her, I sort of grinned at her and I said, wish me luck. So the theme of the presentation this morning, pharmacists are capable providers in an incapable system. And as I shared with you at the start, we're on a roll and your star is rising. And I'm going to share with you some of what's going on in Washington right now in the subject of provider status and our pursuit of that. So I like to say, in the simplest of terms, that I can describe everything that GPhA does in this one sentence. That we promote consumer access and coverage for pharmacists' quality patient care services. Now, I can say that to any audience. I can say it to physicians, to nurses, insurance people, PBMs. I can say it to pharmacists, and it all makes sense. Now, some people like to say in the pharmacy circles, we need reimbursement, we need compensation, we need to be paid for what we do. And you absolutely do. But when you talk to anyone outside of pharmacy, and you put it in terms of the patient, and you say, we want coverage for you. We want you to have access to our services. We have a medication use crisis in this country. Pharmacists are part of the solution, a big part of the solution. So we promote consumer access and coverage to pharmacists' quality patient care services. And I'll come back to that quality piece in a minute, but it's a big part of it. So I mentioned earlier that pharmacy is more united than we've ever been. But I'm sure you've either said or heard the expression, I wish our organizations could work together. We should be as united as medicine. If you knew much about the profession, the medical profession, you'd know that they're as splintered as they've ever been. We need to maintain our focus on our member needs, set by any number of N's and A's in pharmacy, National Association of, American Association of. Those are the kinds of things that people repeat over and over and over again as if they're true. I'm here to tell you they're not true. These things up here are not true. Today, pharmacy is working together. The national execs, my counterparts at NCPA, ASHP, NACDS, AMCP, ASCAP, the list goes on. Don't mean to leave anybody out, but there are a lot of us. We talk on a regular basis, and especially now with regard to provider status. How many of you have heard, raise your hands, have heard of JCPP? Not many. Most of them, the old folks up front. Joint Commission of Pharmacy Practitioners is a group that, as D.C. Huffman, who ran ACA, used to say, we meet, we talk about important things, and we agree to meet again. Well, now, these days, JCPP has an action agenda, and we've done several things in recent times. This is the group of all the N's and A's of pharmacy who get together once a quarter and share our individual agendas, what we're working on, and we talk through things, we talk about our strategy. We have a pretty good agenda every quarter. We bring in important folks to listen to and to change our own perspectives. And it's a very vital, active group. Now, within JCPP, there is a stakeholders coalition of folks who, in 2008, began working around healthcare reform. Well, that stakeholders coalition, we, GPhA, have kept together through iterations of the passage of the ACA, implementation of the Affordable Care Act, and now the same stakeholder group with some minor changes is still together today, focused on provider status. Now, I'm careful to say that GPhA doesn't lead this group. When you ask a group of folks who are the CEOs and the elected leaders of these various organizations if they like to be led, nobody raises their hand. They see themselves as leaders, and rightly so. So instead, the role that we play is one of convener. And we are aggressive listeners. And we bring people together and we challenge folks to think and to talk and to sort of get our collective thinking, believing that all of us are smarter than any of us, and together we can do great things. So I'm proud that our organization expends a lot of energy, staff resources and otherwise, to keep this group collaborating and working together. So one of the things that the group has done is the JCPP group first, and this is a JCPP slide, is that we've drafted a new vision for pharmacy that's more patient-centered and outcomes-focused and team-based. So those are the key points: team-based, patient-centered, outcome-focused. Additionally, I would say that the issue is simple. We've got a medication use crisis in this country. People don't use the medicines well that are prescribed for them and that we dispense. And we can fix adherence all day long. That's great, and it's important that we continue to improve that. It's a big part of what pharmacists have to offer. But it's not all we have to offer. In fact, I would say it's only a small part of what we have to offer the healthcare system today. If people are taking the wrong medicines, which in many cases they are, we've got a bigger problem than if they take their medicines that have been prescribed. So we have a simple issue, medication use crisis in this country. Here are some of the complex pieces of the solution. We need a standard patient care process. I'll share that with you in just a second. But it's fair to say that medicine, all physician training has a single patient care process taught to them early in their training. Same is true in nursing. Nurses have a single care process taught to them. The same has not been true with pharmacists. And so when we talk to our colleagues in nursing and medicine about what we have to offer, they try to fit it into their care processes, and it doesn't fit very well. They don't see it as intuitively as we'd like. So we've created a care process, and I'll touch on that in a second. These other pieces, quality of measures, HIT, standards and accreditation, evidence to support our value and provider status, are all important pieces and all individual pieces that we're working on, but it's not easy. Every one of them takes a lot of energy, and frankly, all of the national organizations and every state organization could use more members. Every one of us deserves your continued support. So, here's the patient care process. I don't expect you to read all of this, but in simple terms, this is what pharmacists do. And the goal is that fairly soon, ACPE, the accrediting body for pharmacy, will incorporate this care process into its standards. That care process then will be taught in every school of pharmacy early in training, and ultimately will be part of practice in coming generations. But it's starting right now. I mentioned that pharmacy is working together. Here are just a few of the acronyms in pharmacy today. Every one of them is an important initiative. Pharmacy Quality Alliance, increasingly important. The measures that they've created are now in measuring what pharmacists do in healthcare every day, and the plans that administer the Medicare drug benefit are measured on their success in these measures. And roughly 40% of how the plans are measured comes down to quality measures that they look at that are addressed by pharmacy. So if you don't know about PQA, if you don't know about STAR measures, you should learn about that. Pharmacy Technician Certification Board gets technicians trained so that you can do more in your practice. I won't go through the whole list. I will mention that the healthcare reform stakeholders are focused on principles and advocacy, and I'll touch in more detail on those in just a minute. But the point is, every one of these collaborations has multiple national pharmacy organizations as members. The HIT Collaborative is very focused on getting pharmacists plugged in to have read-write access into the electronic health record. So we're not just on the receiving end of electronic prescriptions, where we're sort of the wrong end of the funnel, and instead that we've got something to say not only about what we dispense to patients, but what care we provide to them as well. So, I want to talk to you briefly about what's going on with provider status. We like to say there are three pathways: federal, state, and private. But at the end of the day, if we're not on the list in the Social Security Act, we're not put on the team in many cases, whether it's in the state or in private sector. So it's really important, and that's why we're so focused today on the federal sector. We know that when pharmacists get involved, quality goes up, and patient and care improves, and costs go down. But why provider status now? Well, the Medicare, the MTM benefit is growing. There's a lot going on with CMS right now. CMS, the folks who administer the Medicare program and much of the state Medicaid program, have said that pharmacists need to be plugged in better. That maybe we don't need these restrictive networks. That maybe we don't need to limit the access to MTM the way we have in the past. CMS is telling the plans they have to do more with pharmacists. That's really important. A lot of information on pharmacist.com. Many of the other national organizations are promoting your awareness and participation in politically, in encouraging CMS to continue the path that they're on, but there's opposition and headwinds, so I encourage you to take a look at that. Additionally, our quest for provider status has headwinds as well. Getting Congress to focus on it is challenging. The Hill equates our quest for provider status as a quest for fee-for-service payment at a time when all they want to talk about is bundled payment, accountable care organizations, and team-based care. So it's a challenge. Much of the coalition's work around the quest for provider status and our work to get a singular federal ask has been around the complexities of, one, we have MTM bills in the House and Senate that would expand MTM, but that's in Part D as a dog. Meanwhile, we're asking Congress to help us in Part B, where the medical services are provided, and it creates some confusion. Additionally, you could say, well, maybe we should shoot ahead of the duck and try to get ourselves on ACO teams and get us paid within bundled payment, because that's the future. But you know as well as I do that buy low, sell high today is broken. That community pharmacies today who want to make it purely on the margin of your product are having an increasingly difficult time because of the generic cliff, because of the move to specialty, because of restricted networks, because of shrinking margins. It's more and more difficult. We as a profession have to rise up and make it on services that we provide, in addition to continuing to maintain control of our dispensing functions and all of that. So we do have barriers. We have to think about things like which patients, which services, and what pharmacists are involved in providing care as we go forward, because Congress is going to say, well, whatever we do for you, you have to save us money. You can't cost us money. So you have to be savers, not costers. Well, so every time we say we want all pharmacists to do something, well, that's a lot of pharmacists, 280,000. Okay? We want to provide services to all patients. That costs a lot of money. And we want to provide all services. If you say that, then all of a sudden, the score that you get for your request, your ask, is pretty big. So to some degree, we have to narrow those things, which pharmacists, your coalition is saying, essentially all pharmacists. There might be some local credentialing. You might, for example, need certificate training for immunizations, as you do now, that sort of thing. But we're shying away from going down the path of saying only pharmacists who are BPS certified can provide services. We're not doing that. None of the national organizations, save one or two, want to do that, and so that's the direction. We probably will narrow the population of folks that we go for, and look instead primarily at medically underserved population, areas where there's a dramatic need for improved patient care, where there might be a paucity of primary care practitioners, for example. That's one way of limiting it. So there's a lot of work to be done. We have a short amount of time to do it, and yet the world is beginning to wake up to what we have to offer. Harvard Business Review, New York Times, Wall Street Journal, JAMA. JAMA just had an interesting article a couple of days ago published about how patient-centered medical homes may not be as effective as they've been reported to be. I think that's an opportunity for pharmacy, because that early primary or patient-centered medical home that studied in JAMA in Pennsylvania didn't exactly have a good incorporation of pharmacy services. So I think there's some real upside in that we need to examine. U.S. Surgeon General is all over it. We have folks here in the room from Centers for Disease Control here in Atlanta who are big fans of pharmacy. And there's a lot to be done in public health by pharmacists, and CDC is on our side in that, and we want to support them every way we can. Same is true with our Surgeon General, who has been meeting with us on a regular basis, very focused on getting pharmacists plugged in to healthcare because of what we have to offer in primary health. In order for us to scale our services, we have to do three things: specific, predictable, measurable. So, specific, that is, when consumers walk in our pharmacies, we need to be able to articulate what it is we have to offer them. Okay? And they need to be able to go from place to place to place. Payers need to be able to go store to store to store, or hospital to hospital, and get the same services predictably in different places. If we can't do that, it won't scale. And finally, it needs to be measurable, so when people buy our services, they know they're getting something and that their health is improving as a result. CMS, as I mentioned, has 3 different documents out for public comment right now. You should take a look at them. Go to pharmacist.com, you can find them. I would encourage you to comment on those with your own thoughts and observations. Additionally, HHS is on our side, AHRQ, healthcare quality, beginning to see opportunities for pharmacy. In the Affordable Care Act, we have opportunities. Many of you are aware of the White House petition. We've got literally thousands of pharmacist signatures, but we got a fairly disappointing response from the White House, which basically said, just repeated the law and didn't really do much to help us, but we're not done with anything. It wasn't long after that, though, that the White House called us literally right before Christmas and said, can you help us with these insurance exchanges that we're trying to launch to make sure that people get enrolled effectively? And pharmacy has stepped up and done that, as we did the last time with Medicare Part D, but typically with very little recognition for what you do every day when patients walk in and have questions about the ACA and the exchange. So, I've just got a couple minutes left here, but I want to make sure that you know that our organization is embarked on a major campaign to promote provider status. We've hired some folks to help us. We've engaged colleagues in the other organizations. Here are the organizations in the National Pharmacy Coalition. I'm guessing all of you are close to at least one of those organizations, and hopefully you'll continue to do that and continue to increase your support. We are very close to a federal ask. I expect within the next couple of weeks we'll have an ask in the House and Senate, Republican and Democrat, a bill sponsored and ready to go, hopefully by mid-March. So things are really happening fast right now. And we're going to, at some point in the near future, we're going to be pulling your chain and saying, you got to help us, you got to call your congressman and senator and help us. We will pursue a unified ask, and we will do so aggressively. Not without headwind, but as I said earlier, our star is rising. I want to leave at least a minute or two for questions, but I'll remind you that NACDS has a fly-in in the middle of March. Right after that is our annual meeting, and right after that is NCPA's legislative day in Washington as well. So all of those are important pieces of the puzzle, and we're going to need your help. I've got a list of some of the resources that we have available to you here, and I'm going to sort of skip forward so I can land on time with Mr. Bracewell and tell you that the theme for GPha's annual meeting coming up in Orlando next month is the power and the promise of pharmacy. So we were sitting in a conference room and sort of thinking about the power and promise of pharmacy and what's that mean. And we said, well, the power and promise of pharmacy will be recognized when pharmacists can all practice at the top of their license, when we're valued members of the healthcare team, when every patient has a medication checkup, when the healthcare team has access to our services, when pharmacists are embedded in most primary care practices, when pharmacists are meeting the primary care needs of our patients, when standards are met and we're all engaged in improving quality every day, when pharmacists have read-write access to electronic health records, when interprofessional education, the way each of you students are being trained today with your colleagues in medicine and nursing and dentistry, that we practice as a team, when that becomes routine in practice, not just in education, we will have accomplished something significant. When the pharmacist patient care process is taught uniformly in every school, and when all of you get involved in advocating for patients, then the power and promise of pharmacy will be realized. Remember, pharmacy today is more together than we've ever been in my lifetime. The capacity is in place, the awareness is growing, and your star is rising. Thank you.